CanCOVID is an open science collective dedicated to rapidly mobilizing and sharing knowledge to help inform Canada's COVID-19 response. To learn more about us or how to join our community, you can visit our website at cancovid.ca.
Hello, everyone, and welcome to this week's edition of CanCOVID Speaker Series. My name is Rosa Stalteri, and I lead the research and evaluations team here at CanCOVID. And I have the pleasure of introducing you to this week's speakers, a team from the School of Public Policy at the University of Calgary. So we have Dr. Myles Leslie, who's the Associate Director of Research. We have Dr. Raad Fadaak, who is a Research Associate, and also Nicole Pinto, who is also a Research Associate. And our title for today is A Guide to Vaccine Hesitancy Conversations, Building Confidence in Primary Care. So just a few items. We have saved time at the end of today's presentation for a Q&A session. So please do enter your questions in the event's chat box at any point during or after the presentation. And we also have a brief announcement that we will share at the end. So without further ado, I will now hand over the mic virtually to Drs. Leslie, Fadaak, and Nicole Pinto. Thanks.
Mimed mic received. Thank you. Thanks very much to CanCOVID for having us this afternoon, and for everybody who is in the various time zones showing up. 2 o'clock here Mountain, 4 o'clock in Toronto. A real pleasure to be here. I'm Myles, this is Raad, this is Nicole, and I won't hopefully blather at you too terribly long. This is a guide that if you were to ask me like last night as I was watching The National, where even out here in Alberta, where we hear nothing of the East most of the time, we just get angry about it. There was an image of the Premier of Ontario walking to a lectern. And as they walked to the lectern, Rob Ford said, listen, for those who are not vaccinated, I want you to be able to go and have a conversation with somebody who you trust. And I thought, well, that's a really cool starting place, because that's exactly where we started back in January. Our assumption as a set of researchers who do qualitative research at sort of the intersection of policy and quality improvement was that if you can cast your minds way back to January, when there was no vaccine to be had really, that eventually there would come a time where those who were hesitant about the vaccine were probably going to need to be talked to, or would probably want to talk to somebody. And to have an effective conversation with somebody who is hesitant about anything, let alone a vaccine, you probably want to have them talking to somebody who they trust. So Rob Ford suggested that people go off and have a conversation perhaps with their family member or with their neighbor. And at that point, I think I would diverge from where the Premier went with his ideas. Because I'm not really sure, unless you happen to have a neighbor or a family member who is a medical professional, whether the advice that you would go to that person would be for medical advice. We felt back in January that a great starting place was family physicians, that family physicians have these longitudinal relationships, which is to say long-term, over time, they see their patients again and again. And that means that it is a conversation rather than a sort of one-shot sales opportunity. And that takes me to a second point that I really want to hammer home before I hand it over to my colleagues to give you a view of the guide. This is called a guide. It's not a playbook. It's not a tool. A tool implies that you're trying to work on somebody, that you're trying to sort of change the inner mechanisms of their brain. A playbook suggests that you're somehow skating down the ice and stick handling them into doing something that they don't necessarily want to do. That's not the purpose of this guide at all. The purpose of this guide, and one of the major findings from our research, is that you don't aim for yes. This is not about having a conversation where somebody definitely, you win if you manage to get the patient to say yes. That's not a particularly respectful starting point, and it's certainly not a very probable ending point if you just treat it like it's stick handling or sales. It's a guide to having longer, better conversations, and we think that the family docs are really, really well placed to have these. So we started off with the idea that, okay, there's conversations probably being had, and there's stuff in the psych literature, and we wonder if the conversations that they're having matches up to the psych literature. The psych literature suggests that there's a couple of sort of bedrock origins of hesitancy out there. And we started talking to family doctors and saying, so what are you seeing? What's happening in your consult room? And they immediately said, oh yeah, there's lots out there already. The people who we had at Hello are already calling our office in the second week of January saying, sign me up, I want a shot, I want it yesterday. And the people who are worried about it have already been worried for several months. What are they worried about? Well, and we started, as you see on the screen now, building a typology, nice big academic term for a menu, a tree, if you will, that contains a number of different types or sources of hesitancy. We validated this with the family doctors, and then we took ourselves back into the field to ask them a second set of questions. Okay, we've heard from people like you that you're seeing patients who have these kinds of hesitancies, these types. And those might range from, you'll see in a moment, a fear of needles over to poor previous experiences with the healthcare system and everything in between. We've heard from you that you're seeing this kind of patient. What are you saying? They were saying all sorts of different things. And we used a specific technique called motivational interviewing to sort of filter through the ones that were more successful and pick out the parts that would be hopefully replicable in other conversations. There were people who were doing sort of the old-fashioned stuff, which was let's present data and hope that the data argument wins. And as we know, often the data argument doesn't win particularly well. It often, in fact, the literature suggests, entrenches people in their hesitancy. So the people that were having more success tended, as I said before, to be following this idea that I'm not in sales and I'm not in stick handling. I'm in the business of being an ally, and I'm in the business of having a longer conversation. I'm acknowledging the person who's in front of me has real concerns, real to them, and therefore something that we could talk about, as opposed to, no, you don't have to be worried about that. We'll simply get rid of that with some facts, that these are emotional and trust-based decisions. So that's all of the basis of the tool. First phase of research, go out and find out what types there are in existence that the family doctors are seeing. Second phase, ask those family doctors, filtering it through the idea of motivational interviewing, how they're talking and what they're talking about, to provide guideposts, ideas for at 3 o'clock in the afternoon when you're hitting patient 20, and that patient says, yeah, but I'm really worried about X. What do you say about X? What do you say to that patient? That's the genesis of it all. I shall now pass it over to Dr. Fadaak to give you a tour of what was produced out of that work.
Great, thanks, Myles. I'll be sharing my screen here, so you should be seeing the landing page for vhguide.ca. This is our live website, so my intention here is not necessarily to walk you through every page and go through all the content here, because there's a lot of content. It's really just to kind of familiarize all of you with how we laid this out, because again, as Myles said, we collected a lot of content. And so there was a challenge in kind of how to present this with the two use cases that we really saw would be prominent in the primary care setting. The first use case being that kind of synchronous use case of a doctor actually turning the screen around and working with a patient through some of these advice pieces. And then the asynchronous use case, which we thought maybe would be a little bit more predominant, with a physician who would perhaps see a repeated kind of type of hesitancy, an aggregation across multiple patients, and then think through that and want to just spend time with the tool kind of outside of clinic hours, or sitting in bed at night trying to think, are there other strategies that maybe I can think through or glean from my colleagues in other places. So with those two use cases in mind, we really tried to structure this website, which is available on desktop as you see here, but also works on your mobile phone, to really fit those two kind of parameters. So the way we did this was to really structure it into these categories that Myles was talking about. So we have specific vaccine hesitancies. We have an undifferentiated vaccine hesitancy space where we have this advice aggregated for any kind of type of hesitancy, because we recognize that in some cases, these physicians hadn't even had that initial conversation to figure out what that source of hesitancy might be in a little bit more detail. So most of our content really does live in this sort of specific vaccine hesitancies area. Again, I'm not going to walk through, there's lots of categories here, there's lots of content, so I invite you to look at it sort of on your own terms and your own time. But the philosophy behind the way we structured this content was to kind of unfold slowly so that, you wouldn't be overwhelmed with the amount of information that was presented, and you could use this with a few glances and a few clicks. But if you really wanted to dive in, you could see more and more content kind of unfold. And so we also structured this with a lot of feedback from physicians that were talking about, things that they had seen a lot. So fears of needles. Primary care physicians have been dealing with that with their patients for a really long time. It's not necessarily specific to COVID. So we wanted to make sure that we put the stuff that's really specific to COVID, that's new to the COVID vaccines, up top. And we know that, a lot of this is the science and safety concerns, the process of kind of authorization and use and deployment. So things like people that are worried that the mRNA vaccines could alter DNA, or the side effects of the vaccines, or fertility and reproductive impacts of the vaccines. These kinds of concerns were things that we were hearing kind of over and over again. And so in structuring this, it's really to present, a sort of differential diagnosis of, am I talking to the right person here? Some high level things to consider, pragmatic advice that's delivered to you really quickly, a take home message on really, affirming you, giving you some empowering language that, your advice really can make the difference here. And then where the heart of the tool is really in these advice tabs. And these advice tabs utilize this adapted motivational interviewing approach that Myles was talking about, which we formed into kind of our own little acronym, EASE, for these 4.5, 5 steps. Engage with open questions, affirm and reflectively listen, ask for permission, then share information, evoke and evaluate options. And so the way we see this is really just as a cycle of steps. It helped us organize the content that we were getting from these physicians, this advice. So we wanted to kind of structure the content this way for delivering these kind of pieces of advice. So in any one of these areas, you can kind of go in, see little snippets of advice and structure it again into these steps to help structure those conversations. Again, it's really to give people, to take the cognitive load off of physicians and clinicians that are using this and having to come up with their own strategies over and over again. It's a way to think about and structure these conversations. In some cases, we had some really amazing analogies, again, that were maybe a little bit too long to put up front so that people aren't presented with these walls of text. So we really tried to keep those with some fun little sort of deep dive areas where you can take a look at how other physicians are really thinking about, for instance, the mRNA and explaining mRNA to patients, which we know can be difficult because if you use that information deficit model, you're going to lose patients, right? It's too much, it's too complicated. If you're talking about cytoplasm, you're going to lose a patient. So really thinking through some of these analogies and other things that we used. We have a resources tab, which again, it's structured along these hesitancy types that we've organized throughout the tool. These are works in progress. We're working with lots of collaborators to make sure that these resources are tailored and updated to good validated sources that are both patient facing and meant for the clinician working in primary care. So this space certainly is growing for each of those areas. And again, I'm moving very quickly through this because all of this is live at vhguide.ca. So feel free to explore it on your own terms. And we're always here with to answer any questions and respond after this webinar to any of these things. Finally, we have this little section, again, consistently growing, continuing to grow all the time, where we had a lot of, along the way, clinician to clinician advice for, again, how to approach these conversations. Affirming language about how difficult sometimes these conversations can be, and approaches that again really avoid that kind of push toward a yes and really emphasize kind of creating that space of being an ally. And so we really wanted to make sure that those pieces of wisdom, those little nuggets of wisdom, were kept in a tone that was for clinician to clinician sort of advice rather than clinician to patient advice. And so that's what the clinical pearls section is. And I think that sort of gives a general sense of the overview of the way that we laid out this tool. Throughout, I think I just want to emphasize, the effort taken to make sure that our language that we used was both recognizable to physicians and clinicians immediately, but also non-stigmatizing to patients, because we knew that as part of that use case, we would have doctors that would be turning around the screen and using it potentially with patients. And we also knew that potentially patients would go home, or members from the public would go to this website if they wanted to have a conversation with a family member, and we're struggling with some of those conversations. So we really wanted this to be both trauma informed, culturally sensitive, and non-stigmatizing across the board. And so we've taken pains to do that. That's not a finished project, just like nothing else on this page is finished. It's a living space. So we're always inviting feedback on, especially along those lines. And I think one of the biggest areas where that area, where that focus is going to grow is in these sort of trauma sections, where we have sort of community, group, or historical traumas, systemic racism, other areas where, how do we confront and assist people who have those concerns or who have had those experiences, either individually or as part of their community. So I think with that, not to overwhelm you with so much detail and sort of commentary about the site itself, I think I'll just turn it over to Nicole, last but not least, to give a sense of kind of future directions for the site, what we're planning on doing with it, and maybe next steps.
Awesome. Thanks so much, Raad. So as Raad mentioned earlier in his little presentation, he mentioned that it's a living site. So we fully anticipate that we're going to be continuing to update information as the pandemic evolves. And as a result, we have quite an extensive wish list in terms of features that we want to add to the guide. And this has changed quite a bit since we've been receiving user feedback as well. So some of the content that we want to adapt on or evolve is the new hesitancy types. So we recognize that as vaccines are rolled out, there are going to be different conversations being had and different issues raised. Based on the feedback, we heard that people wanted more information with regards to folks who are pregnant and breastfeeding, as well as the option to have like more pediatric focused information, especially now that the vaccines have been recommended for children and adolescents aged 12 years and older. Some features that we want to include as well include a complete French translation so that it's appropriate for Francophone audiences. And we want to include a keyword search and filtering options as well, just to enhance the site and make it a little easier to navigate. And then we also want to make sure that we evaluate the tool. And we want to do this by conducting user evaluations with clinicians and with medical residents as well, in order to assess the user friendliness of the guide and the usefulness of it. Ultimately, we want to understand if this guide is actually helping to change how physicians are thinking about and approaching the conversations that they're having with their vaccine hesitant patients, and if they're really experiencing success with this. And that's where I will wrap it up for today, and I'm sure the team will be happy to answer any questions.
Thank you so much, all. We do have questions in the chat box currently, so I'll start with the first one. And I'm wondering if any of the experts have recommendations on a validated measure of vaccine hesitancy. So questionnaire, brief is preferred.
I will speak on the team's behalf. We do not. So you're looking for, just to clarify the question that I've just answered that I don't know the answer to. I think you're looking for a questionnaire that you would deploy into a general population to find out what a quantum of hesitancy. And if it's a quantum of hesitancy, you're looking to be able to say how much an individual has. This person has, say on a normal distribution curve, this person over here that was calling the family doctor's office in January has an almost zero amount. And if we go through the curve, we come back down again, this person over here that will never have it done because they feel that it's a violation of their DNA has an infinite amount. I do not know of a tool that would get you that, particularly a brief one, but maybe I'm misinterpreting the question. I don't know if Sherry's had a chance to write in and clarify. Sorry.
We can go on to the next question, but Sherry Stewart, when you have a chance, just clarify, we can get to it right after. So we'll go on to the next one. So this is a little long. First of all, thank you so much for the awesome presentation. I know someone who does not want to get the COVID vaccine. When I was talking to her, I realized it's not just the COVID vaccine, it is other vaccine hesitancies. For example, she does not believe in the flu vaccine, and also she is over 50 years of age. but never received a flu vaccine before, which made me realize a simple talk will not convince her that the COVID vaccine is safe and effective, but it is more deep belief system that was not detected up to date because we never cared to vaccinate the whole population till now. So have you considered these types of people in your study?
Certainly. You're right to call out the fact that there were three sort of pill-shaped starter points on that first page, the second of which was undifferentiated hesitancies. I think actually what you'll find is that the undifferentiated hesitancies, if you run through that, is about getting to the pill that was to its left, and that's getting to the differentiated ones. It will turn out in all cases, whether it's a COVID vaccine or polio or smallpox or whatever we're talking about here, that the objections that are being brought, the hesitancies that are being expressed, are in some way, and this is why we began with the psychology literature, related to deep level fears, political misoppositions, that sort of thing. So it is, and this is again why we chose family medicine as a great place to try this intervention. It's very much a peeling the onion conversation. And it's not just for COVID that it's like that. Those differentiated ones also work for non-COVID vaccines. I want to understand where your objections are coming from. I understand that they're there and that they're very deep, and that me bringing a whole bunch of facts to an argument is not how you want to deal with deep traumas, deep fears, deep objections. And so I would suggest that perhaps the existing categories, which are and were researched specifically in the COVID atmosphere, but that probably within those, there are areas that are going to be an overlap for your 50-year-old friend, and that they are techniques for trying to draw out, peel back the onion and see at the center of this is about bodily integrity. I feel like it's not just that I say it about my DNA, I feel like my body is being invaded in some way and this is wrong. Okay, then that's a really big concern. That's not illegitimate. So I think it's probably helpful to think through the tool in that way. It does deal with things that are beyond COVID. The research was done specifically in COVID, with COVID in mind, but the differentiation I think will apply to far beyond COVID.
Thanks so much. And Sherry Stewart did clarify here for use in research, and yes, are they hesitant and why? And also mentioned quantum of hesitancy and when hesitant and why. I don't know if that helps.
So again, I would go back to the idea that this is a lot of the stuff, like there's some really, really good material out there. There's great stuff, and you'll find it in the resource sections, that third tab along in the tool, guide. I keep checking myself on that. In the guide, the third tab along gives resources that are static, right? That will help people in specific moments. And that I think is kind of a problem with a survey methodology. I mean, it's always a limitation when you read the paper about it anyways, but that you get a snapshot in time. And the family doctors are a great place to have the conversation because you're not limited to that snapshot. Also, a sort of combined answer with the previous question, we've seen in talking with, and we did role play interviews with the physicians about how they were doing this with their patients. The patient moves around. It doesn't, the person who has an objection doesn't just say, oh, well, it's against my religion, and then stick there. They might also go right around to, and I'm worried that it's going to affect my ability to have children. So those are two that might end up being related, and you have to have multiple conversations to get to the, oh, so this is really a deep-seated fear about not being able to have kids, is it? Because that sounds really scary. So snapshot views of where people are at with their hesitancy in a moment are probably less helpful in this context. And it's why I'm afraid I'm unable to answer the question about where a nice short tool would be to get those snapshots.
Thanks so much. So our next question here is, in defining your hesitancy types, it seems that influenced by rumors, conspiracies, or misinformation seems to assume that those that have vaccine hesitancy could not have legitimate concerns that are scientifically valid. This does not seem to be covered in any of your categories. Do you guys like to respond to that or clarify?
Somebody else want to take a swing at that one?
Sure. I mean, I can start. So I think that that information is embedded in other hesitancy types. So you'll find pieces of that in concerned about side effects. So I think that there is especially in the affirm step, we really wanted to make sure that physicians were taking the time to affirm people's concerns and not sort of try to, again, with that information deficit model, not try to just sort of overload patients with, you know, information about authorization processes and clinical trials and other things, because I think that everybody is using sort of different sources of information. And so we recognize that affirmation of people's concerns was a really, really critical step to these conversations. And in that, I think, you know, evoking alternative options is also a really critical part of that as well in terms of our acronym. So the influence by rumors, conspiracy, or misinformation is high up on that list because it was a category hesitancy type that physicians were seeing very regularly. But it doesn't mean to imply that people who have concerns about things like side effects from certain vaccines, and especially, you know, some of this advice was captured when the AstraZeneca vaccine was more in use in Canada. And so we wanted to make sure that those concerns were validated by a physician in that conversation, by a clinician, because that is part of, again, building that trust, building that feeling of alliance, and really weighing and evaluating those options for what does vaccination mean for you? How do we make it feel, how do we make it a safe choice for you? How do we make it feel like it's a safe choice for you and an acceptable choice for you? So I think that's a key thing that we really wanted to integrate throughout the tool. So just because that category is there doesn't mean that people who have concerns cannot have valid concerns. You know, our tool is definitely focused on validating those concerns and making sure that those are part of that better conversation about vaccination that people are having.
Central to the idea of the question uses the word legitimate, and I'll use it as a verb, legitimate. The idea of affirmation is that this is a legitimate problem. You can legitimate that concern. It's not a matter of saying, oh, well, because you're not scientifically grounded, why did you come to this conversation at all? No, this is a conversation, because that's shutting down a conversation. Of course, you can have legitimate concerns, and they can be scientifically driven. You have an advanced education and say, I don't understand why everybody's running towards the mRNA vaccines when there's other stuff that's behind it in the approval chain, and we should maybe be talking about that. That's a legitimate concern. There is no way that the tool writes any of that off. The idea is that in testing this with family physicians, we needed to have category names that touched down with them so that they could rapidly move through the menuing system to find stuff. This is why, as Nicole said, we really want to have this search capability as well, because stuff can be slotted in many, many different ways. So our assumption is not that somehow people could walk in and if they had that, then that's just not legitimate. It's built into it that at the affirm stage, you're saying, no, that's a real concern. I get it.
Thank you. So our next question here is, your guide appears, which is awesome, at first glance to assume users are all on the same side of the issue. Some practitioners are hesitant themselves and tell their patients to refrain from getting vaccinated. Did you run into this in your research, and does the tool account for this?
It does not. We did run into it, and the tool does not account for it. The tool assumes it is www.vhguide.ca. It is open to everyone. The idea here is that nobody can come and say, oh, you created some sort of elite mind control thing that is going to be only accessible to doctors. Anybody can come and see this. We are assuming that people who agree with the idea of vaccine and people who disagree with the idea with the vaccine should have equal access to this. There's no smoke and mirrors to this. We're not trying to do mesmerizing or anything like that. This is about a better conversation between a practitioner who does feel that the vaccine is in their patient's best health interests, because that's the definition of the family doctor's job, is to be their health partner, ally, and get them to the place that they want to go. And so those practitioners who are hesitant probably wouldn't be using the tool, but they have access to it, is the idea.
Thanks so much. So our next question here is, have you received any initial feedback from physicians on this guide? If so, could you share some of that with us?
I think, Nicole, could you talk a little bit about our testing phase and where that came from? How that's been?
Yeah, so we have received quite a bit of feedback from physicians, both like during the development stage. So it was an iterative process where we would design and develop something and then show it to the doctors, and they would say, no, this needs to be tweaked, and so forth, and so on and so forth, and we kind of move forward like that. And with the version that we have now, we have received quite a bit of positive feedback from the guide. In terms of usability, I know that some folks have said that they would have preferred a search function, which is what we're going to be incorporating in the future, and just some additional content. Yeah, Raad or Myles, do you want to also comment on that?
No, I think that about covers it. I mean, yeah, this again has been, as Nicole said, just to repeat what she said, it's been designed from the get-go iteratively with physicians and clinicians to ensure that it meets those sort of demands of use that they're looking for. And so, and it's, again, it's a living space. So just because we released version 1.0, anything that you, in terms of feedback for design changes, for content changes, we have that little contact us button there, and that's an open invitation to participate in that process of refining this. This is a living tool that will be updated basically all the way through 2021 and into 2022 as the landscapes change. So it's meant to adapt to the changing landscapes of vaccination and the pandemic.
Thanks so much. So we're a little bit over time. Is it okay if I just let in one last question and then we'll end the session for today? Lots of questions today. So hello, thanks a lot for the information. I wonder what kinds of resources did you use to develop the vaccine hesitancy guide?
I'll take an initial pass and then we can keep going. Go back to the bit where we're just going first time into the field to develop the typology. That's the psych literature around vaccine hesitancy. We all had an instinct that there's probably truth here, but there's probably that usual problem with experimental psych stuff that it's got an awful lot to do with 18-year-old college students from the United States. So let's figure out how this is actually playing out. It turns out that those deep structural things, which are fears and traumas and that kind of stuff, it would appear to be there. It's not particularly actionable. It's just nice to know that it's there. This is a very, this project is an action research project. So it's about being able to get resources, as Raad has described, that reduce cognitive load into the field as fast as possible. And so those initial psych literature pieces that we had in our hands got used. We identified stuff and then it rapidly transferred into immediately applicable KT kind of stuff. Sorry, using academic speak there, knowledge translation, trying to get it off into the field. And then I'll leave somebody else, whoever wants to pick it up, to talk about motivational interviewing as a resource in us doing this and making the tool.
Yeah, I mean, I would actually maybe go in a slightly different direction than motivational interviewing as a resource, which it certainly was. And I think we've really stressed that we really took inspiration from that. But I think one thing that we really focused on in making this tool was we've seen a lot of, during COVID, the fire hose of information. And for clinicians, I think they're so inundated with resources pages that often, very often, especially in primary care, link out to other pages. So we've seen this especially, in the acute care setting as well, but really primary care often gets these kinds of agglomerations of links that you just kind of keep pointing you to new places. And so we really wanted to build a self-contained ecosystem of advice that's pragmatic and practical. So you weren't going to be clicking and then have 30 tabs open and think, well, who actually validated this and where did it come from? And is this a resource I can adapt to my context? We really wanted this to be primary care driven, specific to primary care, and you can live inside that website and it is a resource. And so it wasn't so much about really pulling in other resources and adapting them and then, cleaving them up and stuff. It was about really, how can we build up this content kind of from scratch with fun role play interviews on top of a validated typology and really create that, again, self-contained ecosystem of advice. So that was, I think, the approach and the innovation that we wanted to put forward. So yeah, a little bit of, I think, a different approach than typical kind of resources pages or other things. So yeah.
Okay, great. Well, I'm going to end the session here for today. So I just want to say on behalf of the CanCOVID team, I'd like to extend our thanks to Drs. Myles Leslie, Dr. Raad Fadaak, and Nicole Pinto for their time today in walking us through the vaccine hesitancy guide. And of course, thanks to all today's attendees as well. And just before we go, please note that we will be pausing our events for the month of August and will resume in September. In the meantime, we will continue to share our knowledge products and resources through our various channels. And finally, if you'd like to receive updates and aren't already in our newsletter list, please be sure to visit our website and subscribe there. So this concludes today's event. Thank you so much again for joining us, and have a great rest of your day.
We would like to thank our speakers and members of our network for their continued support and participation in Canada's pandemic response. If you are interested in learning more about CanCOVID or joining our Pan-Canadian COVID-19 Research Network, please visit our website at www.cancovid.ca.